Continuing another great day here at the Texas Association of ACOs, and actually get to visit with an organization that here in DFW I know very well. I'm visited with Michelle Mirkovic today. We're going to talk a little bit about Southwest Health Resources. So what are the models that you're looking at? What are some of the challenges that you're looking at? And frankly, where do we go from here?
That's a great question. And to your point, we are a joint venture between UT Southwestern and Texas Health Resources, so an academic medical center and a faith-based health system. A little bit diverging priorities between the two health systems, but still very collaborative and very willing to come to the table and try to figure this out, and very invested in value-based care. And so Southwestern Health Resources, we do their contracting, but then also we're that ACO arm, and really trying to, we were really excited about access for a minute. And then, of course,
so you saw the payment?
We saw the rates and the balloon kind of air went out of the balloon. But I still think there's opportunity there to, again, how do we partner with some of those folks, vet them, and then maybe pilot one over here with this provider group and one over here with this provider group, and then figure out what's working, because the providers just need help because they're trying to see 35, 40 patients a day. And, I didn't say, we've got the two health systems, but then we've got 340 something individual or independent providers in their clinics, just trying to keep the lights on, and they're trying to see 35, 40 patients a day sometimes, and they don't have time to vet the next access participant or guide model participant or whatever. And I think one of the things that we are looking at is how can we best support those providers, because they're the ones seeing the patients. And instead of talking to them about, well, Dr. Smith, you really need to lower your total cost of care because we're a total cost of care model. And Dr. Smith is like, huh? And so really helping, we've got a large group of wonderful folks that do our provider relationship management. And so they actually are in the clinics. They see 75% of their physicians or their practices in person every month. And the rest of them might be virtually, or some of them are every other month for the provider, that's their preference. But they're actually in those clinics, having those conversations across the kitchen table or across the desk about, here's how we can help your practice. Here's how we can help you lower your total cost of care so that you do get your bonus at the end of the year, because, we want to help you get that bonus because it helps everybody. But at the end of the day, it helps your patient. Because you have a patient sitting out there that can't get to see you because they don't have transportation. We provide transportation for your patients. Or we've got patients, did you know that your patient was in the hospital last week? Well, here we built you a widget so that when you go into, not your EMR, but you have to go into our Pop Health software, but someone in the office can look every single day at that widget to see the ADT feeds. These are your patients that were in the hospital over the weekend. How powerful is that to be able to provide that information? And then, by the way, we want you to see them in the next 14 days.
Right.
So how can we help with hey, baby steps, baby steps. So, just having those conversations and being able to support those providers, because like I said, at the end of the day, they're just trying to keep the lights on, and we're there as their support system. It's different for the health systems because they've got their own quality department, their own RAF department, all of that. So they can do all of those things to support the providers, but the independents don't have that. And so trying to figure out how we can best support them. And our medical director does the same thing. He goes out to the practices and says, hey, this is what we're seeing in your practice. How can I help you understand that these providers that you're referring to, or, that your outcomes aren't what we need them to be, and here's why.
Right.
How can I help?
Yeah, and that's really interesting too, because you all have, I believe it's called the Extended Physician Network, right? So you kind of have the specialty wraparound for the independents as well. So
APN, Extended Physician Network, exactly.
Yep. So you've got the primary care physicians that are within the ACO that you guys are providing all of the support to. Then you've got this extension of a network of specialty that's over the top. And so you're actually able to see that and help them as well. So not only the primary care is navigating the lower costs of care for better outcomes, but then working with the specialists to show how they can create performance as well to drive that to the middle. Is that how that model continues to work?
Yes, and we've actually stood up a new program. I say I didn't have anything to do with it, but our organization started really greater level of engagement with those specialists. We had not had as much engagement, but now each one of those providers has a provider relationship manager. And now it's not going to be a monthly meeting. It's going to be a lighter touch, but they're still going to have one person in the organization to call, whether they have a question about MIPS or, I'm not getting any referrals from Dr. Smith anymore. What happened? Being that liaison between the PCP and the specialist to really make sure that we're cementing those relationships. And then also between the specialist and our health system. So if you can't get, block time in the hospital, well, let's see what we can do about that. We have someone that's responsible for the relationships with the hospitals and the providers. So really helping support those specialists, because as CMS has signaled, we got to start managing those specialists. The ASM model, CJRX, other things that they're coming down the pike, they really want the specialists to have some skin in the game as well. And I think that that's something that we recognized, that's the signal the CMS is putting out. So let's see how we can start managing those relationships as well.
Yeah. Well, and that's what I'm seeing too. So I kind of look at the trajectory of what's happened probably over the last 18 months. And I say the CMMI strategic refresh, I say the CMMI data sharing, right? And so what's happened is they've realized that 70 to 80% of the cost sits on the specialty side of the continuum. And so while we've done a great job of value-based care from a primary care perspective, I think that the government is making a clear assertion that we have to find ways to engage specialists, and that's the next evolution. And so it's either bringing them together or creating models within those specialties. So when you look at team, which is mandatory, that's a signal that we're going to continue to take downside risk and that we're going to kind of push people in that direction. You look at what we're seeing from ASM, that's kind of taking it back to an ambulatory setting, but it's taking it into the specialty models. You look at CJRX, which we could argue is a little bit of a spinoff of VBC, but you should be well prepared to move into that model if you've done well in those models previously. And so I think that's very telling. The other thing that I see, going back to your point about access, is, look, I was also woefully underwhelmed by the outcome-based payments, but I think that the message was telling to me, which is, I have said there's going to become a time, maybe, in the outpatient long before the inpatient, but there's going to become a time where no outcome, no income. And it's the first time the government's taken a stance that we're going to create outcome-based payments. And so I think that's the message that we needed to hear. I think when I look at what's coming out with LEAD, a 10-year runway tells me that the government sees the value of a long-term longitudinal care model. And so I know you guys are currently in REACH. Is that going to transition over to LEAD? Are you looking at MSSP? Where do you guys sit, and what's the future look like for you?
We've got some consultants coming in helping us figure out what makes the most sense for SWHR. We're making an application for MSSP. We're making the application for LEAD. We actually probably going to make 2 applications for MSSP in case we decide to split the network, which, neither here nor there. We don't know what the next iteration is going to be. We're depending on our actuaries and folks that are a lot smarter than I am to help us figure that out. But we are committed to value-based care. We are committed to Medicare and understand that fee-for-service. If you really start reading the tea leaves, CMS is saying, we're not going to do this fee-for-service for much longer. You guys are going to have to come along with us in value-based care. Fee-for-service does not work. They stopped it in the hospitals, home health. SNF is still on a per diem, but, all of those are paid on DRGs, which is basically a capitated payment. We're going to give you this amount of money, whether they stay 1 day or 27, you pick. And it's how you manage that inpatient stay is how much money you get to keep out of that set amount of money.
Yeah.
Well, it needs to be the same thing for providers because, a lot of them just don't get it, and they don't understand that if they, again, go back to the CHINMED model, the more you manage your patients, the better you manage your patients. Maybe we don't save money tomorrow or next month or even a year from now, but in the long run, we're trying to save the Medicare trust fund.
Yeah.
And I'm going to need it probably before you do. And so I am counting on there to be some money in the Medicare trust fund when I get there. And we all want that. And, with the high cost of medications and all the cool procedures that we can do now. It's like at some point we have to figure out how to control those costs and figure out, I know that you get paid more if you provide this injection compared to this one, but this one will save the Medicare Trust Fund. And maybe let's start with this one and see if it works. I'm talking about the eye injectables, the Part B drugs.
Right.
And also the whole catheter fraud and skin substitutes and all of that kind of stuff.
Well, let me tell you, David Colonis and I just talked about fraud, waste, and abuse because he just testified before the Ways and Means Committee, and
somebody needs to.
The skin substitute was front and center.
As it should be, because the MACs have a contract with CMS to pay appropriately for, there's rules and guidelines. We don't really have an LCD at this point or an NCD, but they shouldn't be paying for something that is not appropriate for care. You don't need a skin substitute after a Mohs procedure. That's dumb. Okay, let's just say that out loud. That is inappropriate. You also don't need a skin substitute on a hospice patient. That wound is not going to heal. They're at the end of life. Let's just put on an alginate, keep them comfortable, set them on a donut or whatever, and help that patient be comfortable. And so, I really feel like the MACs have let CMS down by not managing that cost and not managing those payments because, we're in the billions of dollars at this point.
Well, you made a great point. David made the same point, and the conversation I had with him is the challenge is that we're held responsible for the accountability from an accountable care organization perspective, but we don't have the necessary control.
Right.
And so how do we balance the two? And he made the exact same point. He said, you got to lean on the MACs. The MACs have got to step up. We've got to be able to do this. That how do we shorten the gap between accountability and control? And you're absolutely right. You talk about kind of the shifting away from fee for service. And commercials play a role in that. My challenge is the fee for service chassis is hard to break, and the wheels inside the system tend to move slow. But what I have found is that people that understand and invest in value-based care in the broader sense of the term is really creating better efficiency and better throughput in an organization or in a healthcare system that's already capacity and resource constrained, because the demand for healthcare is inelastic. It does not matter. There is always going to be demand. And so how do I keep Michelle out of the hospital because she doesn't need to be there, to make room for John to come into the ED because he does need to be there? And then how do I move him efficiently and effectively through the organization and get them home so that they can recover and that we don't have to worry about all the other downstream effects that happen within the four walls and hospital-acquired infections and all of these things that exacerbate and complicate the care model. And so I think that's where we have to go. The other thing I would say, and you kind of alluded to, for me, for the longest time, it's not even so much about the Medicare Trust Fund, which is obviously a big component, but I've long said that value-based care is planting the tree to planting a seed for a tree whose shade I will never sit, because we've got to get upstream. We've got to get preventative. I need to save this for my kids and my grandkids. And if we're not going to look at pediatrics and we're not going to look at how do we partner with employers and how do we drive down total costs, we're going to continue to exacerbate and create more expense. And so I'm really excited to hear how things shake out for you guys, what path you do decide to choose, and what the future holds. So I'm glad you had a great time. I've really enjoyed this conversation. Michelle, it's been absolutely great. Anything you want to tell the audience as a final takeaway? What should they be looking at?
Like I said, there's so much to look at in the future. There's all these new models. There's a lot of different, again, I go back to the AI. Somehow we've got to figure out how to get our providers to understand that this is going to help you in your practice. And so as ACOs and clinically integrated networks and all of that, I really think it's on us to vet all of that and really try to figure this out and then try to anticipate what CMS is going to do next so that we're ahead of the curve and we're not constantly trying to keep up. 2 years ago, I think it was 2 years ago, they signaled the ASM model.
100%.
And so if you were reading the tea leaves then, which we started contracting with physical therapy clinics, outpatient therapy, brick and mortar, and outpatient therapy in home. It's like, hey, we need you guys to start a therapy first program to help our PCPs understand that, say, for example, if you show up to the provider office, I hurt my back yesterday. oh, well, here's an anti-inflammatory, muscle relaxer, and the orthopedic surgeon's card. Maybe an x-ray. We'll do an x-ray too, right? Of course, got to do imaging. And so trying to break those referral patterns to say, look, if you send them to therapy first, you're going to improve your outcomes. And maybe we don't ever have to get to the orthopedic surgeon's office. And so, we've got to keep thinking forward about what's coming next and how to continually improve what we're doing. You can't just sit here and think, well, this is how we've always done it. You've got to continue to innovate because innovation is everywhere. And
I love
AI
that you
is
said that.
a huge opportunity. I love change. I'm one of those weird people that I get so bored doing the same thing over and over again. I want to see what we can do next.
That's why I chose healthcare.
If you don't like change, you should be a plumber because that's one of the only industries that has not changed probably in the last 60 years. Whereas healthcare, we have to continually innovate because there's always going to be something else out there that will improve care. And if we don't look for it and connect, we're going to miss the boat.
I totally agree. And, not only would I say we need to be looking at what's coming, and I think that, the anticipation is still somewhat reactionary, but I think the best way to align the care model, if you want to call value-based care, in a nutshell, is to ensure that the right patient gets the right care at the right time in the right setting. And if that's your business strategy and that's your philosophy and that's your model, you're well positioned for whatever model comes out next because you're already doing the right work. And so that's where I think there's hope. That's where I think there's promise. I want to come all the way back around to one of the first things you said about the excitement and all the change and working in healthcare. I would say what I love most about working in healthcare is that as hard as it is and as challenging as it is right now, probably harder than it's ever been, it is the most exciting, most energetic, and most purpose-filled time we've ever seen in healthcare because we are starting to get into that era of actual transformation. And all of those things, as hard as it is, as challenging as it is, there's nowhere else I would rather be than right here doing this work in healthcare right now. So
Totally agree.
thank you for the perspective. Thank you for the opportunity to visit. And I would just say this, let's move healthcare forward together. Michelle, thanks so much for the time.
Pinnacle is your partner in the business of healthcare, nationally recognized for helping clients manage risk, improve performance, and drive innovation. For more information, visit our website, askphc.com. For more information on our guest or to learn more, please visit their website.